Questions that we have that we can quickly take on? Dr. Goldstein, are you around here? I have a question for you. You showed very nicely in a graph what we see every day, a discrepancy between the TAPSE and the actual fractional shortening of the cavity. Sometimes the RV looks really bad and the TAPSE is preserved, and vice versa. How do you manage those discrepancies on a day-to-day basis?
By doing what we do for almost everything in the lab, and that is look at multiple parameters, decide which, especially when there's discordance, which one may be wrong and why. So you're not stuck with choosing between those two. That's not an uncommon situation. Remember, TAPSE can be regional. It doesn't have to represent the whole lateral wall. The base may be preserved. Half or more of the ventricle, right ventricle, may be abnormal, and it can be abnormal for that reason. But look at the technical aspects of those. See if there are problems. I could show you many slides with PVCs, atrial fibrillation, where TAPSE can have multiple numbers. So those are some of the kinds of things that can mess you up, et cetera. Look at the other parameters, S prime, your eyeball, and piece things together, et cetera.
Good. Glad to know that we're doing the right thing. What happened to the questions? So how does echo play a role in diagnosing amyloidosis? I think I'll answer that very quickly. Basically, if you see a lot of LVH that doesn't match the blood pressure or the QRS complex, if you remember the case he showed you, the QRS was basically normal. There was no high voltage. And then you look at the LVH, and it was massive. So that discrepancy between the amount of LVH and the QRS voltage is one clue. The other thing is biatrial enlargement, patients not doing well. As he mentioned, blood pressure was not a big deal at that time. You really have to be intuitive. If you don't think about it, it will go by. And unfortunately, we do see a lot of patients that have gone by many doctors for a long time. By the time they show up, they're so sick that at that time it's very hard. So that's a good question. You have to really keep it in your radar.
And in addition, as clinicians too, a couple of other things that are quite important, in terms of physical exam and findings in these patients, particularly with the wild-type transthyretin. Bilateral carpal tunnel syndrome actually is common, if you ask that, and it seems to predate cardiac involvement by about 5 to 10 years. They actually have a series from Cleveland Clinic recently presented on that. And second one would be spinal stenosis as well. A biceps tendon rupture, the Popeye sign, it's another finding that can be seen as well with the wild-type transthyretin.
Yep. I'm going to add to that. I teach our fellows to look at three things. If you've got thick walls, normal-sized cavity, and any degree of hypokinesis, think amyloid. Don't mean it will always be amyloid, but think amyloid. And then look at, is it restricted pattern, big left atrium, some of the other echo features, even thick atrial wall, thick valves, pericardial effusion, small. Then get tech power phosphate scan or MR or even biopsy in select patients. Go to further tests.
So from a CMR point of view, if there are there any CMR clues that explain why this train pattern shows some apical preservation?
Yeah, that's a great question. So from the CMR, there are some times that you see the infiltration occurring predominantly at the base. It tends to start. This is actually where most of the myocardial mass is as opposed to the apex. But I would caution about this concept of a relative apical sparing that we see on the echo. If you find it's great, if it's not there, don't stop. Or don't take amyloid out of the plate.
Good point.
Okay, so it's very specific, but not enough sensitive. So.
Yes, I have a question here for Dr. Carlos. Dr. Carlos, you said you were using some biomarkers and also the ejection fraction patients started on chemo, is that right?
Yes.
Okay, what biomarkers were you looking at? Are there thresholds, and when do you start looking at it? And that's one part. The second part of the question is, how do you handle a patient who has already an underlying cardiovascular disease or event and also concurrently being planned to be started on a chemotherapy? how do you triage this? How do you follow this? Are there work being done on this already?
Sure. So let me address the first question. So in terms of biomarkers, there are two biomarkers that have been used clinically. One is troponin, the way that I show it. The other one is BMP. I have to be honest with you, BMP is a surrogate for elevation in left ventricular filling pressure. So I think that if you are really interested in early detection of cardiotoxicity, there will be nothing early about finding your BMP. Now, the BMP is helpful if you are having somebody coming, and sometimes in the cancer patient, it's not that simple to figure out the syndrome of heart failure. So I will use it, sometimes they will come, they are fatigued, the hemoglobin is down, they're having some swelling in the legs, and you're kind of confused whether it may be the heart failure syndrome. If the BMP is normal in this population, then that will be helpful. Addressing your second question, that's probably more complicated. And then it always comes to the risk-benefit relationship when you're making the decision. I mean, at the end of the day, you need to remember that these patients are being treated for cancer, and we always try to do everything in our capacity to facilitate the regimen. So it's always a big discussion with the patient, with the oncologist, what are the risks that you're going to be involved if you are dealing already with cardiac disease.
Thank you.
So an important question that came is, how do you account for the effect of intravascular volume alterations on straining in chemotherapy patients? And I imagine that this is coming. There was a recent publication from the MRI lab from Greg Handley in Wake Forest, where he raises concerns that, as you already know, in the setting of chemotherapy administration, you're going to have changes in your intravascular status. You are going to have vomiting, you're going to have diarrhea. And just like Miguel mentioned, with ejection fraction, which is absolutely load dependent, guess what? Strain imaging is exactly the same. You are preload, you're afterload dependent. The very first thing that we teach our fellows is that just like when you are reporting gradients across the mitral valve, the next question always is, what is the heart rate? Same things happens, with global longitudinal strain. The same question is, what are the loading conditions? You always need to report the blood pressure. In the expert consensus, the way in which we jump over that obstacle is we recommend to do the global longitudinal strain evaluation the night prior to the patient getting the next chemotherapy, so that any potential effect, any nausea, any vomiting, any diarrhea that the patient could have had that could mess with the results will already be gone.
We're going to take one last question because I think we need to take the break and I need to go over to the lab. So can a patient with only a low EA ratio have normal diastolic function? The answer is yes. In fact, there's a lot of elderly people that have an EA ratio of 0.8, 0.85, and they have E primes that are right in their age range, and they're perfectly healthy and happy. And the second scenario is when people are volume depleted. So again, older folks, particularly as they approach their 60s, at the same time they get diarrhea or any situation that they became volume depleted, the EA ratio can be under 1, and yet they still can have normal diastolic function. So just the EA ratio alone is not just by itself a marker of impaired relaxation. And I think we probably want to go and take a little coffee break. If you want something else than coffee, you're going to have to walk out of here and come back. And I'll see you by way of camera in a few minutes.